Welcome to our video on headaches. Let's begin. Here are the topics we're going to discuss in our lecture. Let's start with primary headaches, particularly migraine. We'll cover migraine by going through its definition, pathophysiology, clinical presentation, diagnosis, and management. Migraine is an episodic severe primary headache disorder that often affects females. It may have a hereditary pattern. The pathophysiology of migraine is complex and contains different processes. However, what we need to know is that abnormal activation of trigeminal vascular system leads to increased release of vasoactive mediators and neuropeptides, such as calcitonin gene-related peptide. This causes neurogenic inflammation and vasodilation that induces the migraine headache. Now, what is trigeminal vascular system? In simple words, the trigeminal vascular system is composed of neurons that innervate the cerebral and meningeal vasculature. The cell bodies of these neurons are located in the trigeminal ganglion. Let's discuss the clinical features. The migraine attack may first start with a prodrome phase that occurs 24 to 48 hours prior to the headache onset. Patient in this phase can experience feelings of depression, irritation, and food cravings. The second phase is aura. Aura presents as focal neurologic symptoms that typically precede the headache. These are commonly visual symptoms. For example, patient may experience seeing flashes of light or complain of scotoma. The aura can also, less frequently, be auditory, somatosensory, or motor. The third and most important phase of migraine attack is the migraine headache. Migraine headache is classically throbbing, pulsating, and mostly unilateral pain, although it can be bilateral in children. It lasts 4 to 72 hours. Patients typically experience photophobia and phonophobia. Therefore, they seek relief by sitting in the dark and silent environments. Other associated symptoms include nausea and vomiting. The last phase of migraine attack is postdrome phase, during which patients may experience feelings of exhaustion. It is important to note that migraine attack can be triggered by emotional stress, menstruation, weather changes, and lack of food or sleep. This image shows how visual aura may look like. We can notice how the view looks distorted here. This animation is another example of how the visual aura may be. We can see the scintillating scotoma, which looks like a flash of light. The diagnosis of migraine is primarily based on history and clinical presentation. However, imaging can be performed to rule out other causes like a brain lesion or a pseudotumor cerebri. Management consists of two parts, abortive and prophylactic. It is very high yield to remember these two therapies separately. Abortive therapy of migraine attacks includes non-steroidal anti-inflammatory drugs like aspirin and ketorolac, as well as acetaminophen. Triptans like sumatriptan are migraine-specific agents are usually used and act as 5-HT1B1D receptor agonists. They're typically used in moderate to severe attacks. We can also use ergots, such as ergotamine or parenteral dihydroergotamine. Ergots act as 5-HT1B1D receptor agonists and alpha-adrenergic blockers. This image shows the mechanism of action of triptans. As we mentioned, triptans are 5-HT1B1D receptor agonists. They bind to these receptors on cerebral and meningeal blood vessels and cause vasoconstriction, therefore reversing the vasodilation responsible for inducing the headache. They also act on the 5-HT1B1D receptors on the trigeminal nerve endings in the brainstem and block the release of vasoactive peptides such as substance P and neurokinin A, and hence decrease transmission of pain sensations. In abortive therapy, one important point to remember is that simultaneous use of triptans and ergots is contraindicated. This is because the risk of serotonin syndrome and coronary vasospasm is significantly increased. Other choices of abortive management include calcitonin gene-related peptide antagonists such as rimegepant or ubrogepant, as well as antiemetics like promethazine and dihydroergotamine. Prophylactic therapy of migraine is indicated in settings of frequent and long-lasting headaches, or when there's a significant disruption of patient's life quality. It begins with avoidance of triggers such as emotional stress, in addition to making lifestyle changes like having good sleep hygiene and exercising regularly. Pharmacologic choices include beta blockers, for example propranolol and metoprolol. Antidepressants commonly used are amitriptyline and venlafaxine. Anticonvulsants like topiramate. And calcium channel blockers such as verapamil. The last thing we'll talk about are medications used for acute management of migraine in pregnant patients. The first-line medication is acetaminophen or combination acetaminophen metoclopramide. Second-line choices are aspirin or NSAIDs, such as naproxen or ibuprofen. These are safest in the second trimester before 20 weeks of pregnancy. Please note that ergots are contraindicated during pregnancy because they can induce uterine contractions. Let's try a question. A 25-year-old woman comes to the physician due to severe headache that started 1 day ago. She states seeing flashing lights before the onset of unilateral pulsating headache. The patient asks the doctor to turn off the lights and close the window to block the traffic noise. This is her 5th episode of headache in the last 6 months. NSAIDs, acetaminophen, and antiemetics have not helped her previous episodes. Which drug class can be used to abort the acute attack of this patient's condition? This patient presents with severe unilateral pulsating headache preceded by flashing lights. This description is consistent with migraine headache accompanied by visual aura. The patient asks the doctor to turn off the lights and close the window to block the traffic noise. This behavior is consistent with photophobia and phonophobia, which further supports the diagnosis of the migraine headache. NSAIDs, acetaminophen, and antiemetics have not helped her previous episodes. The most effective drug class used to abort the acute attack of migraine is triptans. Now that we're done with migraine, let's go through the next type of headache, that is cluster headache. We'll cover a cluster headache by going through its definition, clinical presentation, diagnosis, and management. Cluster headache is an episodic, severe primary headache disorder that often occurs in males. Let's directly move on to the clinical features. Cluster headache is usually unilateral, especially periorbital pain that is pain locating around the eye. It lasts from 15 to 180 minutes, way shorter than a migraine attack. Cluster headache is characterized by daily attacks recurring for a few weeks followed by a period of remission. The patient presents with ipsilateral autonomic symptoms including lacrimation, conjunctival injection, rhinorrhea, and nasal congestion. Agitation or hyperactivity is also characteristic, as opposed to patients with migraine headache. Partial Horner syndrome of ipsilateral ptosis and meiosis may also be seen. Lastly, attacks can be triggered by lack of sleep and alcohol. Let's do a quick review question. A 32-year-old man comes to the emergency department reporting severe headache that started half an hour ago. The headache is unilateral and most intense around the left eye. The patient experiences this type of headache every 3 months. The physical exam reveals left-sided ptosis and anisocoria with smaller left pupil. Which 2 additional findings may accompany this patient's condition? This male patient presents with severe unilateral headache most intense around the left eye. The patient experiences this type of headache every 3 months. These findings are consistent with the diagnosis of a cluster headache. The physical exam reveals left-sided ptosis and anisocoria with smaller left pupil. Ptosis and meiosis suggest the partial Horner syndrome that commonly accompanies the cluster headache. The 2 additional findings that may accompany the cluster headache are rhinorrhea and lacrimation. The diagnosis for cluster headache is mainly clinical, dependent on history and clinical presentation. We may do few investigations to rule out the other diagnosis. For example, we can perform an MRI during the first episode to rule out brain lesions or other lesions causing Horner syndrome. For the acute management of cluster headache, we use high-flow 100% oxygen. Triptans like sumatriptan are also used. Alternative drugs include ergots and lidocaine. For the prophylactic management, we prescribe verapamil, which is a calcium channel blocker. Topiramate, which is an anticonvulsant, is another option too. Let's discuss tension headache next. We'll cover tension headache by going through its definition, risk factors, clinical presentation, diagnosis, and management. Tension headache is a primary headache disorder and the most common type of headache. Risk factors include fatigue, stress, anxiety, depression, and lack of proper sleep. Please notice how these factors overlap with inducers of migraine and cluster attacks. Let's discuss the clinical features. Tension headache is bilateral pain as opposed to cluster and migraine. The pain is mild to moderate, non-throbbing, constant dull, and aching like a tight band around the head. Pericranial muscle tenderness is a prominent feature. The headache may last from half an hour to a whole week. Just like other primary headache disorders, the diagnosis of tension headache is mainly clinical. We may perform imaging tests to rule out other conditions like brain lesions and giant cell arteritis. Coming to management. The mainstay is avoiding the risk factors and triggers such as stress. Relaxing massage may be useful. The acute management of headache requires use of simple analgesics such as acetaminophen and NSAIDs like ibuprofen. Combining caffeine with analgesics seem to produce more effective results. Prophylactic management may be required for patients with frequent headaches or disrupted quality of life. We typically prescribe tricyclic antidepressants such as amitriptyline. Behavioral therapy may be used as well, such as cognitive behavioral therapy and using stress reduction techniques. In this illustration, we can see the comparison of all three types of headaches. Please remember that migraine and cluster headache is unilateral, while a tension headache is bilateral. Also remember that cluster headache is commonly periorbital and is more prevalent in men. On the other hand, migraine and tension headache are more prevalent in women. Let's move on to secondary headaches. We'll cover this topic by going through the definition, causes, red flags, clinical presentation, workup, and management. Secondary headaches can simply be defined as headaches due to an underlying medical condition. There are a lot of causes of secondary headache. We're going to mention some of them briefly. These include vascular causes such as subarachnoid hemorrhage, subdural or epidural hematomas, and temporal arteritis. Infectious causes such as meningitis, encephalitis, and cerebral abscess. Pharmacologic agents like nitrates and chronic use of analgesics, tumors or intracranial masses, and different other causes like hypertension, pseudotumor cerebri, and pheochromocytoma. Now let's pay some special attention to red flags. These are certain features that, when they present, further evaluation of headache is needed due to suspicion of underlying causes. First, we have the sudden onset of headache, within seconds to minutes. Also, new onset of headache in old age, specifically patients who are more than 50 years old, is concerning. A headache accompanied by change in mental status, signs of increased intracranial pressure such as papilledema, seizures, or any focal neurologic symptoms and signs is also a red flag. Lastly, new onset headache that is associated with heavy exertion, head trauma, fever, neck stiffness, rash, HIV infection, or cancer certainly need further evaluation and workup. So, the clinical features of secondary headache are pretty variable depending on the underlying cause. For example, the patient may present with confusion, motor, or sensory deficits. Workup is usually dependent on the suspected cause. Some useful tests include complete blood count, measuring erythrocyte sedimentation rate, and imaging modalities such as CT scan or MRI. Finally, management depends on addressing and correcting the underlying cause. Let's reinforce what we learned with a quick review question. A 62-year-old woman is brought to the emergency department due to sudden onset severe bilateral headache. She has a past medical history of hypertension and migraine, the acute episodes of which are treated with ibuprofen. The physical exam reveals a confused patient with slurred speech and diffuse extremity weakness. What is the best next step in the diagnosis of this patient? This patient presents with sudden onset, severe bilateral headache. Physical exam reveals a confused patient with slurred speech and diffuse extremity weakness. Although she has a past medical history of migraine, her current headache with focal neurologic deficits suggests more ominous underlying cause, such as a stroke. Therefore, the best next step in the diagnosis of this patient with headache due to suspected stroke is non-contrast head CT. Finally, let's try a board-style question. A 21-year-old woman presents to the emergency department with progressively worsening right-sided headache along with nausea and vomiting. Headache started 7 hours ago and it was preceded by weakness of her left hand. The headache is unilateral, pulsating, and most intense around the right eye. She has had similar episodes for which she takes naproxen. The patient is under a lot of stress in college and sometimes feels tension in her neck. Vital signs include a temperature of 36 degrees Celsius, blood pressure of 110/75, heart rate of 91, and respiratory rate of 14. ESR and CRP are normal. The physical exam is unremarkable. The patient wants to lie in a dark, silent room. Which of the following is the most likely cause of this patient's symptoms? A. Migraine headache, B. Cluster headache, C. Tension headache, or D. Temporal arteritis. The female presents with unilateral pulsating headache along with nausea and vomiting. The headache was preceded by weakness of her left hand consistent with aura. The patient wants to lie in a dark, silent room, which suggests photophobia and phonophobia. Considering that her vital signs and inflammatory markers are normal, all of these findings are consistent with the diagnosis of a migraine headache. Therefore, the correct answer is option A. Here is a slide reminding us of the clinical features of the migraine headache. Let's discuss why other options are incorrect. Option B, cluster headache, is incorrect because it is more common in males. Additionally, the cluster headache is a unilateral periorbital pain commonly accompanied by the partial Horner syndrome, rhinorrhea, and lacrimation. Most of these features are absent in this patient. Option C, tension headache, is incorrect. Although this patient is under stress and sometimes feels tension in her neck, this is not enough to diagnose her with the tension headache. Additionally, the tension headache is a bilateral headache not accompanied by nausea, vomiting, aura, photophobia, or phonophobia. Finally, option D, temporal arteritis, is incorrect. First, temporal arteritis is more common in elderly women. Second, it's commonly accompanied by jaw claudication and intermittent visual disturbances which are absent in this patient. Physical exam in the patient with temporal arteritis would have shown the tenderness and the firm cord-like structure on the patient's lateral forehead. And that concludes our lecture on headaches.